As a lot of you know, the Board of Representatives meeting and the infrastructure is there for us to communicate with you, and also for the different units and unit representatives to communicate with us with what is going on in cardiothoracic surgery in the country and how we can help all of you. So thank you for everything that you've been doing, and thank you for being the Board of Representatives and helping us do a better job for cardiothoracic surgery moving forward. Today we've got a busy programme. As I said, it's important for us to communicate with all of you about what the different initiatives the SCTS is doing and the hard work we're doing on behalf of the specialty, but also for us to hear from you about the different issues going on in the unit. So we would value questions during the Q&A session, or if there's anything pertinent after the presentation, but we'll try and keep it to the 2 Q&A sessions before lunch and before the end of the day, once you've heard some of the presentations. But it's really important that we get an understanding of what is going on in the different units and how we as the SCTS can help moving forward. So we've got some presentations. We want to continue the theme of the SCTS research that we launched at the annual meeting. So we'll have some presentations from adult cardiac, thoracic and congenital, and then reports from the different subcommittees and the different initiatives that we're running throughout the SCTS executive. So I'm just going to give a quick update on some of the major things that have been going on with the SCTS, and then we'll move on to the different reports from the different units. But yeah, thank you again for all that you are doing. So today I'm just going to give you a brief overview of some of the major initiatives that are going on. To start with the cardiothoracic database, which will allow us as SCTS and you as members to take back control of the data that you're doing, of the operations that you're carrying out. So it's a big initiative that we're trying to drive moving forward. Talk about some of the major changes in SCTS research and SCTS education, as well as just an update on the constitutional review that we've been talking about over the past year, before talking about the big report, an article that was published a few weeks ago about sexual misconduct and surgery, and before talking about some of the major issues that we're interacting with NHS England with regarding supplies, Pectus and elective recovery. So to start with, the cardiothoracic surgical database is something that we've talked about at the annual meeting and is really important for all of us. Demetrius will be giving a presentation later in the morning, but I just want to really encourage all those units that haven't yet submitted their data sharing agreement to have a look at it and try and contact us if you have any questions, because the more units that engage in this, the bigger and more powerful the database will be, and will allow us to do all the important things that a database can do, whether it's outcome monitoring, mortality or morbidity, benchmarking between different units within our country, but also internationally, allow us to set up a SCTS-driven national audit strategy, also from you as units, rather than looking at audit on a local level, for you to look at it on a national level. So to give all of you access to that data that we will be collecting, and also to look at long-term outcomes. I've talked about morbidity and mortality, which are short-term measures of what happens to patients, but I think it's important that we also look at what happens to patients in the long term. And also then it will allow us to move forward with some of the different research projects we're doing, whether it's data-enabled trials or link up with big data, such as through the BHF data set. So I really encourage you. Demetrius will give you more details about the project in his presentation later this morning, but I really encourage those units who haven't yet submitted their data sharing agreement to work with us about moving forward with that, so that we can have a powerful database to shape the care delivery that we give. Elizabeth and Debbie have been doing a phenomenal amount of work through SCTS education, whether it's through the different courses or fellowships, the new ones that they've introduced over the past 12 years. And there's a whole host of resources on the website, whether it's through the YouTube channel with previous videos, the operative video collection, the simulation program they're doing. Elizabeth will be giving a presentation later today, but just a big thank you to the SCTS education team for the phenomenal amount of work that they're doing and putting on resources for all the consultants, trainees, NTNs, NHPs. All parts of our workforce are covered by the education program. Major parts of the meeting today will be looking at SCTS research. in the UK, we have a phenomenal opportunity to change the care and the delivery of care that we give to our patients because of the infrastructure we've got set up in this country, because of the hard work of the research team in terms of the priority setting partnerships, the cardiothoracic interdisciplinary research network, the infrastructure we already have. We have a great opportunity to deliver high quality, world leading research. But it's incumbent on all the units and members getting involved in that research, becoming PIs, associate PIs, and joining the research projects that we're setting up. So Nigel, Babu and Enoch will be giving presentations about the different subspecialty research initiatives that are going on. But again, it's about getting all the units and members engaged in this, and I'd strongly encourage you to help us with move forward some of these research projects. As you'll have heard over the past year, we've been talking about a review and changes to our constitution. We've gone through a big consultation process, and as many of you have been at the SCTS annual business meeting in June, you'll know that the amendments that we were proposed were approved, which namely would include adding 3 additional trustees to the executive board. So 1 nationally appointed trainee representative or trustee voted by the NTNs, a trust appointed doctor trustee voted by the trust appointed doctors, and an NHP trustee voted by the nurses and allied health professionals. This is a big step moving forward. I think we're one of the only surgical specialties that have done this, and it recognises the team aspect and the contribution of the extended surgical team to the delivery of cardiothoracic care. So that's a big part of what we're going to be doing moving forward. And in addition, we've added a 4th appointed trustee in addition to the honorary secretary, honorary treasurer, and the meeting secretary. The communication secretary will also become an appointed trustee. So we will now move from 11 to 15 trustees to run the charity. As I said, this is a big step forward in the way the SCTS will be run, and it's a big thanks to Rana and the team who've been working hard with the lawyers, the charity lawyers, to make these changes happen. Soon we'll be able to put a timeline on when we'll be able to introduce these trustees once we've got approval from the lawyers about the new constitution being accepted. A lot of you will have seen this article that was published in the British Journal of Surgery about sexual misconduct in surgery. It has some truly shocking facts about what has been going on and is going on in surgical practice throughout the country. This isn't a cardiothoracic specific report, but it applies equally to our specialty. And when you read, I would encourage, we sent the article to all members earlier in the month. I'd encourage you, all of you, to read the article and the report that I'll talk about in a minute. It has some truly shocking figures, and some of which I've put on the graph up there, that 80% of men, 90% of women have witnessed sexual misconduct in the past, sexual harassment in the past 5 years. Over 60% of women and 20% of men have experienced sexual harassment in the past 5 years. And then you see some of the other figures in terms of sexual assault. 36% of women, 17% of men have witnessed it, and 30% of women have experienced sexual assault in the past 5 years. It is incumbent on all of us to do something about this, to change the culture, and I'm going to talk about that in the next few slides. Alongside the article that was published in the British Journal of Surgery, the Working Party in Sexual Misconduct and Surgery group have put out this report. And again, I'd encourage all of you to read it, because it is something that we can all learn from. And it's got a number of suggestions, and there's a number of actions that we as the SCTS are going to be taking forward. But it is specifically to say that as practitioners in cardiothoracic surgery or surgery in general, it is important that we create surgery to be a safe and welcoming place to work in. That we encourage inclusivity and diversity in our specialty, so that we do not push women away from our specialty because it's a place that they do not enjoy working in. That we create a safe reporting infrastructure, so that when these assaults or harassment takes place, people have confidence that the reporting will have an action. And that there is robust mechanisms for trusts and employers and other organisations to take action against perpetrators. Because if you read the report, there is a significant lack of trust in the infrastructure of what goes on, and so a lot of people are not reporting it. And then finally, to create a safer working environment, because we know that where practitioners do not feel safe in their workplace, it has an impact on patient outcomes. So it is incumbent on all of us to take on board what has been written in this and try and change things moving forward. This is in parallel with earlier in the month, I think it was the 4th of September, the NHS released their organisational charter on sexual safety in healthcare. And there are a number of recommendations for all NHS trusts and organisations to take on board, and that they will be made accountable for this over the next 10-12 months. I think by June 2024, all trusts have to put this in place. But this doesn't just exist for trusts' responsibility. This is all of us as individuals, as well as our society and SCTS. Moving forward, we as the Cardiothoracic Specialty Association are working with the other surgical specialty associations. There's a meeting next week, as well as with the 4 Royal Colleges, about developing a national strategy. This isn't a cardiothoracic surgical problem. It exists in cardiothoracic surgery. This isn't a surgical problem. It exists in surgery. And it isn't just something that exists in medicine. You've seen the reports in the police, the ambulance service, the Houses of Commons. This is a problem in society, but it's incumbent on all of us, especially those of us in positions of responsibility, to try and do something about it. And it's about developing a national strategy that we can implement to try and change the culture of zero tolerance, of understanding what goes on out there. We're trying to develop things about education so that we can be part of national mandatory training. You all do mandatory training on medical gases and other things. We're trying to develop something that this will be part of. Every member of the workforce will have to undergo this training before working in this environment. As mentioned earlier, the reporting structure fails a lot of victims of the sexual misconduct, and it's about developing a robust reporting structure that people have confidence in, that they feel something will be done about it. As mentioned earlier, there's the NHS Sexual Charter that's been developed, and it's incumbent on the organisations to have a policy to address all of these issues. And as part of that, we will all be expected to conduct ourselves on a specific code of conduct. And we're also working on putting a number of resources and signposting on the SCTS website so that all our members will at least have access to that. I'd welcome all the different initiatives that those of you will have experienced in your own trusts locally, so that we as a society, but also as individuals, can try and change what is going on. As well as some of that work that we're doing with the Royal Colleges, we are also working very hard on your behalf with NHS England. A lot of you will know about the problems with waiting lists and elective recovery. We've had several meetings with NHS England recently to try and tackle some of those issues that you're experiencing in all of your units. And the different initiatives will come under 2 broad categories. Either that we need to increase capacity, and that'll be through waiting list initiatives, extended operating lists, surgical hubs, so operating outside your own units through surgical hubs or the independent sector, and also then ring fencing ITU beds. And we're also trying to push for derogation from cardiothoracic surgery from industrial action, because we know the impact that it has on patients on waiting lists, not only psychologically but physiologically, and it alters their prognosis. So we are trying to make changes that will affect the capacity that you are able to deliver cardiothoracic care, but also the efficiency that you do that, and that is through ERAS and the perioperative guidance, through the Centre of Perioperative Care, day of surgery admission, a lot of you have worked on. Virtual wards exists in many medical specialties, and we're trying to introduce that within the surgical specialties, both pre-operatively and post-operatively, to free up ward beds to allow better patient flow through the system. Pooled waiting lists for some units, they still have high waiting times for individual surgeons in units, whereas other surgeons have shorter waiting lists. So the importance of making sure patients are not being put at harm because of that. Using theatres more efficiently through smart scheduling, and reducing non-elective workload. We know the IHU patients in cardiac surgery have a bigger footprint. So if we can try and optimize them to reduce their need for the in-house system and bring them more as electives, we may be able to have better patient flow through the system. But again, it's through meetings like this where all of you work in different units and you've all got best practice that you can maybe share with us and that we can disseminate amongst the other units. It's really incumbent that whatever works in some units, we may be able to disseminate, understanding there is geographical variation. All of these ideas are great, but they all are incumbent on staffing. And we've all seen the issues that we have in our own units about staffing, and recruitment and retention policies through the NHS is crucial to underpin all of this. A lot of you in cardiac surgery will have seen this that came out, one of the NHS responses to how they can deal with waiting lists, to say, well, why don't we send all the patients for TAVI? As the SCTS, we fundamentally disagree with this, that patients should be given the treatment choice that is appropriate for them, not just on the waiting times. For a lot of patients with low and intermediate risk of cardiac surgery, surgical ABR is the gold standard. For those where there is equipoise, they should have an MDT discussion, but they should not be given a choice just purely on waiting times. And in fact, in a lot of units, TAVI waiting times is longer than surgical waiting times. We've put out a survey. I think it will come up in the adult cardiac surgery report later. Thank you for all of you, the unit reps that have responded to that. But for those who haven't, please send us that data, because it's really powerful when we sit down with NHS England to say, actually, this policy document is wrong. And we've asked them actually to revoke this document because we think it does not do patients a great service. I would encourage you all to be advocates of your patients. But please send us your data to help us challenge NHS on this. We've also been working with NHS England because of the supply issues. A lot of you have been having perfusion supply issues. Some of it's related to the war in Ukraine, other geopolitical issues, Brexit, global supply chain, but some of it is also related to MHRA regulation of new devices. So we're trying to work with NHS England to try and speed up that process where alternative catheters, devices exist, that we can try and make some progress with that. So you'll have seen that early in the year there was problems with intra-aortic balloon pumps. Some of it was related to supply issues. Some of it's related to a field safety issue put out by the major supplier. We believe a lot of that has improved, but I'd value hearing some comments from you if that's still an issue on the ground and what we can do to help. We've been working with NHS England to put in a sort of a strategy, contingency strategy, to try and help and ensure all units have supply and access to these important devices. Aman will be talking a little bit later about Pectus Surgery and Pectus Care. Until February, when we had our best practice event, the flyer on the right, there was no surgery for patients having Pectus deformities in England. But through a lot of hard work through the Pectus Working Group and Aman in NHS England, we've now got a national centre, BARTS, that is conducting MDTs and operating on patients. There's soon going to be requests for expressions of interest for a second national centre, hopefully in the north. Clear referral pathways developed, and hoping with that there'll be regional centres that'll be able to refer into this. Joel and the team have developed some fantastic best practice guidelines. Whilst the surgery currently only is for patients with very severe Pectus deformities with a Haller index of greater 3.25 and other specific symptoms, those with severe Pectus deformities are going to be put into the NIHR prospective randomized study, which Enoch may touch on later. And we're also trying to put on some resources on our website and get a lot of more people involved to try and change how Pectus care is delivered moving forward. And then following that really thought-provoking presentation at the SCTS annual meeting by Professor Buta about sustainability in healthcare, sustainability in surgery, and specifically for us in cardiothoracic surgery, we've put together a working group which will be moving forward with collecting data on what exists in cardiothoracic surgery, start off some research projects to see how we think we can improve our carbon footprint, and then hopefully develop some best practice guidance, as well as collaborating with other national organisations, Royal College, Centre of Sustainable Healthcare. So just some of the different initiatives that we're doing. Whilst I'm standing here talking about what the SCTS is doing, this is down to a lot of hard work from a lot of members, SCTS executive who drive the vision and strategy for the society, the subcommittees who take all of these different initiatives forward and all the members in there, the course directors and faculties who deliver the education programme in their own free time, the SCTS administration, Emma, Tilly, Micah, Mara and Tate, who do a phenomenal job behind the scenes in making the SCTS function. All of you as BORS representatives and all your members in your units for delivering the fantastic healthcare for our patients. And just to say a big thank you to everyone for what you're doing. And please help us and communicate with us about trying to change things moving forward. So thank you for all your support. This is a programme of what we're going to be doing for the rest of today. As I said, I'd welcome any questions if you've got any burning questions now, but a lot of it will be covered in the subsequent talks later today. But just to say thank you again for all your help.